the setting of an acute illness, but for somebody to even like a 37-year-old, if she did have a pneumonia, for that to be causing confusion, that um, just like makes me more concerned. So I think to start with those two symptoms together making me think of an infection, and either like a primary infection that's causing delirium, or I guess not primary, but like a systemic infection that's causing delirium, or something that's involving the CNS, especially because she's not the usual um, delirium candidate. So I think I'm mainly thinking mainly infection at this point. We don't have a time course yet. And we don't have any more information about like how severe those two symptoms are.
Shannon, that was fantastic. You nailed it, my friend. I love, love, love that you initially uh, just thought about like 37, yeah, and this is odd, right? Like 37-year-olds, usually healthy with good reserve, to have like shortness of breath and confusion. We should take that seriously. And so kudos to you for that. And I 100% am there with you. I think the big question is, in a 37 who is this 37 year old, is if this is a person who has a lot of medical issues, then probably compared to like another 37-year-old without anybody, he might have a little bit of poor reserve and more susceptible to different pathologies. Or if this is a healthy 7-year-old with no medical conditions, then you have to kind of think about like the severity of the insult, right? Is it like so bad that this patient is coming into the emergency room with dyspnea and confusion? Shortness of breath, dyspnea, and confusion, really, really, really big differentials, right? Even if you do a Venn diagram of them, that is still a lot of things that we have to be concerned about. So I'm not going to run any differential, like I'm not going to think through many specific diseases yet, because we just need a little bit of more information to dig deeper. Well, my initial thoughts are like, hey, is this dyspnea the primary driver? Is as Robbie likes to say, is it the center of gravity of this case is the lung? That with hypoxemia can cause like if this patient is like super hypoxemic or hypercarbate, that can lead to altered mental status, without lovely miss mnemonic being like a metabolic, like toxic metabolic encephalopathy. Or is this the same pathology that is affecting the lungs and the nervous system, leading into confusion? So I think those are the two hypotheses that I'm running, is that way, whether it's like a same disease, two organ manifestation, one pathology leading to another. So I'm really, really curious to hear more.
Yeah, sure. So actually, the history of present illness is a little bit long. It started 3 months ago with a productive cough with widening sputum and fever of 39 Celsius. So the doctors prescribed antibiotics because they thought it was a pneumonia and didn't get better. And the cough continued. The dyspnea also continued. The fever also continued. 50 days before, the dyspnea got worse. And 5 days before, the dyspnea got even worse. In all the process, she had lost 10 kilograms, and she was diaphoretic in the emergency room and very thirsty. That's all. Maybe I could give you the past medical history, the social history. Actually, she was from Venezuela and moved to Peru 2 years ago because of all the social and economic crisis there. She was a English teacher, no remarkable past medical history, no medical allergies. Yeah,
Gabrielle, I think this is a fantastic place for us to stop and reflect. And I think um, the the discussion that Shannon and Charmaine had was really helpful because I think it literally says, don't commit to anything and study the lay of the land. And that seems like it seems tempting to be able to say more, but if you zero yourself into a smaller circle than you possibly can, you make a grave mistake, I would say. But here we're getting what they asked for. We're getting a little bit more data to work with. So Azim, if we just study I think there's a couple of dimensions to it that we should probably first independently analyze and try to put them together. And the way my mind is tracking it is there's fever, there's cough, there's non-improvement with antibiotics, which I feel like is in one corner, and then the other corner is the weight loss and the diaphoretic and thirsty a lot. So why don't we study them separately and then see at the end if we can try to put them together? So what are you thinking about the first part, the cough, the kind of lung stuff? What's your analysis of that?
I don't want to like bias myself already, but I recall a few cases a few weeks ago of a similar HPI aliquot, and the discussion centered on if you had a pneumonia that was resistant to antibiotics, you should consider like fungal sources of infection. That's something I'm considering. And then if you go down that line of thinking, then you want to know the immune competency or the lack thereof of this patient. And also considering we're talking about a patient from South America, I suspect when we discuss cases from that region, that's something that is a little bit more on your radar.
Yeah.
So that's the first aliquot. I mean, or it could be a pneumonia that's just sort of more resistant, I guess, to certain antibiotics. But as Charmaine and Shannon were talking about, I think now infection is rising on my list of etiologies to really try to focus in on.
100%. I'm right there with you. I would say that thinking about, there's often this call to have a schema for calf mimickers, and like what could look a lot like calf. And I think that the range of presentations that could mimic community-acquired pneumonia are so enormous that my mind, and I'll speak for myself, is unable to make a schema for community-acquired pneumonia mimickers. Is it because the syndrome is mimicking cough, or mimicking shortness of breath, or mimicking leukocytosis, or mimicking a chest X-ray infiltrate? For me, all those are very different schema. So I'd be really curious how the diagnosis of community-acquired pneumonia was made. Was it based on a fever and a cough, in which case I have to think about bronchiectasis, or think about pharyngitis, or think about rhinitis? Was it made because there was a chest X-ray infiltrate, in which case I have to run the mimickers of what causes a chest X-ray infiltrate? So for me, I struggle with making a list of mimickers of community-acquired pneumonia, because I think for the analysis typically begins with what construct did you use to make that diagnosis, and how did that construct fall apart? And here, I will make note of the fact that we are talking about the lungs. We have paid little to no attention to the heart, even though we started with shortness of breath. And I just want to make that explicit. The reason that all of us are jumping to the lungs initially was because there was a cough, which localizes much more to the lungs than it does to the heart. But you have to recognize that pulmonary edema, or anatomic compression of cardiac structure, anatomic compression of pulmonary structures by the heart, like a large left atrium compressing the left main stem bronchus, can do it too. So the cough is good, but not perfect. What reinforces the cough being pulmonary diseases is the notion of inflammation. If you are dealing with an inflammatory thoracic syndrome, the focus of inflammation is often in the lung and the pleura. Cardiac inflammation, it does exist, of course. There's pericarditis, myocarditis, endocarditis, but cardiac inflammation is so much less common. Think about how common is pericarditis, myocarditis, and endocarditis in comparison to pneumonia or pleural effusion. It's much less common. So the cough, whenever you have inflammation and cough, you're centered on the lungs and the pleura. But the other finding here is the weight loss. A lot, but not all, cardiac disease results in weight gain. And so here you can't put endocarditis off the hook for sure, but you're much more likely to be in the lung. And then I think that's where you have to go back and be like, what did they find in the lung to make their differential diagnosis around? Was it an infiltrate? Was it nodules? Was it a cavity? Who knows? But I would say that that's what helps generate the differential diagnosis. So I'm right there with you. Could this be the wrong bug? Could it be fungal? Could it be the wrong drug that the patient got? Or could it be a non-infectious condition? I think that analysis was superb. How do you think about the thirst? By the way, I just to be honest, I've had about 600 mLs of water in 20 minutes. So I'm like, does this apply to me? But how do you think about that? How do you think about this condition in general?
Previously, I thought Tiago mentioned one time in a chat that thirst is, I guess, more often incorrectly associated with something like SIADH. That's something I used to think, and then I reviewed the physiology. So that was the first thing that came to mind when I saw thirst. The diaphoresis and the thirst together, I guess for me, when you're talking about mimics, about maybe confusion or in the setting of mist, actually, the mnemonic, that may raise the level of some kind of endocrine pathology higher. So I guess that's something you have to also consider. So something like hypoglycemia or something like that could be going on, perhaps, or DKA, I guess, worst case scenario.
The nail. See the nail? This is the nail, and this is you. Boom. That actually hurt a little bit. I don't know where to add, so I'm gonna just give you a little bit of spice to work with. People drink a lot because they drink a lot, and it's no big deal. I don't have any problems right now, and I'm drinking a lot. So a lot of driver of increased thirst is just primary polydipsia. And some patients drink so much that they overwhelm their kidney, but this increased thirst may be a response to just being ill. I'll tell you that when I feel ill, I tend to drink a lot more water because that's what I've been kind of coached to do. But if the increased thirst is pathologic, the question is it in response to solute or is it the primary driver? So your increased thirst, if it is pathologic, is often a response to increased water loss. So you're trying to make up for water that you are losing, usually through urine. And the question often is, what is driving that water loss? Is it loss of ADH and the inability to reabsorb that water? And that is essentially diabetes insipidus, because you're not making ADH here, or you're not letting ADH do its thing in the kidney. So again, to reframe the question, most increased thirst is just because you're not making up water loss, you're just drinking more and more because you think you need to. But if you're trying to make up for lost water, the question is, why is the water being lost? And diabetes insipidus, itis central, or nephrogenic is less common than the solute causes. And the solutes are things that drag water out of your body. And that's where glucose comes in, diabetes mellitus. So said simply, increased thirst is often a physiological response to an illness. But if it is pathological, there's some diabetes going on. Is it diabetes mellitus or diabetes insipidus? So here, how would you make progress? You'd get a finger stick and you look at the specific gravity of the urine. And both of them will tell you if there's a kind of diabetes going on, mellitus or insipidus. But overwhelmingly so, people drink a lot more and feel a lot more thirsty when they're sick and they don't have diabetes. At least I hope so, because that's certainly what's happening right here. Okay, all right, Gabriel, back to you, my friend.
Yeah, excellent discussion, guys. So temperature was 39 Celsius. Heart rate, she was tachycardic, 126. Pressure was 90/60. And saturation of oxygen was 88%. The BMI was like 70. She was very thin at that moment. In the skin exam, she was pale, and she had erythematous rash over the chest and painful nodes over the bilateral lower extremities. They were kind of reddish, erythematous-like. And in the oral cavity, they noted a ulcer with definite boulders. In the respiratory exam, in the respiratory exam, the murmur was lowered in both lung fields. there were crackles, diffuse crackles over the lung fields. Cardiovascular exam, no remarkable. Abdomen exam, also not remarkable. And neurologic exam, Glasgow was 13/15. There were no any focalizing signs, no meningeal signs like there wasn't any nuchal rigidity or Rudzinski sign or Kerniski sign. And maybe, guys, would you like to share the X-ray or maybe in the other aliquot?
Oh, whatever you want, Gabrielle. You're the boss.
Okay. So please allow me to share it. Yeah, sorry, I can't.
You have all the power.
Okay. Yeah. So I don't have the radiology report, but I remember it was something like bilateral infiltrates, and they describe as reticulonodular infiltrate bilaterally.
Amazing. Wow. Shannon, we have so much to discuss. Maybe we can bring back the board and then think about the physical exam finding. Gabrielle, thank you so much for this fascinating case so far. And starting with the vitals, so it was like febrile, tachycardic, blood pressure was in the 90s, hypoxemic to 88%. What are your thoughts, Shannon, on the vital signs? And then we can go from there.
Yeah, I keep trying to look for something to kind of narrow down from the buckets of like infection, autoimmune, and malignancy any further. So the vital signs do make me like, she's the tachycardia, hypotension, and fever. It just feels a little septic-y. So that I think feels more likely to be seen with a bacterial infection, although I don't think we can like rule out the other things. And then what's confusing is that the chest x-ray doesn't look at least like a typical bacterial infection. That may be something like strep pneumoniae or something that can be more acutely fulminant and cause sepsis. I usually associate with like a unilateral like infiltrate in one area instead of this diffuse. I don't know if it started maybe more looking like a typical bacteria and now it's progressed and even looks potentially like an ARDS type chest x-ray. And not quite, but like if it was something that we can't really see that it was a localized infiltrate that's now everywhere. But yeah, I think from the vital signs, it does make me more concerned for like an acute infection that may warrant like empiric antibiotics now. Even if it ends up being something more rare, it feels like that's where she's headed.
You are on a roll, my friend. And I know we don't have the board up yet, but what of the exam do you remember? She had like an erythematous rash and these nodules in her legs as well. Yeah, what are your thoughts on that one?
Yeah, the rash on the chest is harder to know what to make of, but the rash on the legs, like these, I think just erythematous nodules sound like erythema nodosum, which I don't think really helps us narrow it down too much because that can be seen with a whole variety of like viral, bacterial, and I think fungal infections. I do think that I do think that they are seen in both fungal infections and TB.
Mhm.
And then I don't know what the epidemiology of sarcoidosis is in South America, but in South Carolina, it's pretty common. And
Mhm.
again, I don't know if all of those would fit with like her vital sign abnormalities or be able to explain those, but
Mhm.
that's kind of what I made of those nodules, that they could be, again, still concerning for any kind of infection or autoimmune and maybe specifically sarcoidosis, but I don't know if that's going to present with like tachycardia and hypotension.
Yeah. Um, Shannon, you're brilliant. That was an incredible discussion. I couldn't agree with you more, and I keep saying that. And based on the vital signs, you're absolutely right. This patient is sick. This patient is febrile, tachycardic. Sometimes, especially women in 30s can have blood pressure in the low 90s. But, if you're not sure about the trend of the blood pressure, just pretend this person is also hypotensive and hypoxemic. So your instinct to be like, hey, I need to treat this, like give fluids, stabilize the patient is absolutely the correct one. And it just kind of tells us like how sick this patient is, like how fast we need to move both in the therapeutic realm and the diagnostic reasoning realm to get to the bottom of this. And your instinct about like, hey, this patient is sick, if they're not improving with a little bit of fluid, then for me to start empiric antibiotics, no one is going to fault you for that. I think that would be the right decision to make. If the patient fails to improve with a little bit of resuscitation, then sometimes like we do, depending on how sick the patients are, our therapeutics should come before. And I totally love that you interpreted the erythematous nodules as erythema nodosum. I did that too. And I think just to take a step back, the big question that I'm asking with this information that is provided is that, like, hey, is this a person with an autoimmune disease in the background that has another insult like an infection on top of it? Or is it something that can all be explained by infection alone? Yes, like, you mentioned TB, you mentioned sarcoidosis. Yes, those things can make people sick, but I do wonder about whether there is like a double hit going on here. Is that like, hey, because of an underlying autoimmune disease, the patient's like a little bit sicker, and on top of that, has an infection, or is this all infection? I think both are good hypothesis to have, and I will be working them in parallel, just to think about like the erythema nodosum and see if it's helpful or not. Like erythema nodosum, 50% are idiopathic, right? The other 50% that is secondary. The most common things to kind of think about in a and also like medications is one to think about, especially like in a woman, if she's on a birth control, that can cause erythema nodosum. Your antibiotics can cause it. Post-strep infection can do it. And in terms of like the autoimmune and more infectious realm, like sarcoidosis, IBD, Behçet's are part of that. And more in the infection realm, you think mostly about granulomas like Mycobacterium, and as you mentioned, endemic mycosis, and malignancies to keep in mind, the lymphoma, leukemia. Although I would say thinking about the autoimmune and infection buckets first, and then having the malignancy in the background. And a 37-year-old is how I would personally approach it. And layering on the ulcers in the mouth is also very fascinating. So thinking about the ulcers in the mouth, it kind of like makes me think a lot about like autoimmune diseases in a woman, like Behçet's, IBD. They tend to do it, as well as like infectious etiologies, and also the what's going on in the internal, like local oral pathology. So the ulcers in the mouth, the erythema nodosum, thinking about like a systemic like granulomatous infection like TB, or thinking about more like autoimmune disease in the background, and what to make of the lung with the reticular findings, in addition to kind of like this diffuse crackles. I think the question is that more representative of interstitial lung disease, versus more, is this an bilateral kind of a patchy infection that we are seeing? I think like the ILD people can develop over time. She's young, 37 years old, they can have like exacerbation of it. It can get complicated by an infection versus all this being a pulmonary manifestation of another infection. I think they're both can be, they both are plausible at this time, but it made me pause to think about, with the crackles and the bases and reticular findings, to think a little bit about like interstitial lung diseases as well. So I think getting labs would be really, really helpful to kind of, and I would probably think about a CT if I'm really worried about kind of like if this is more interstitial lung diseases, to get a better sense of that. Any other thoughts, Shannon, before we give the mic back to Gabrielle?
Yeah, I actually think that your point about the interstitial lung disease or pre-existing autoimmune condition could just be helpful for thinking about, like, it is actually maybe surprising to think that somebody with 3 months of symptoms is then presenting acutely, like just looking like hypoxic, like her vital signs being so abnormal, and like that it's gotten worse, like maybe there's 2 processes. So I really like that.
Yeah. Thanks, Shannon. Gabrielle, I'm at the edge of my seat, my friend. Tell me more.
I love that. I will give the labs. So hemoglobin was 4.9. Leukocytes were 1,970. Platelets were 150,000. Albumin was 2.1. Sodium was 140. Potassium was 4. And chloride was 133. She had some cultures of the blood cultures. Both 2 of them were negative. Uroculture was also negative. I think I have. Okay. So they also did a gene expert for TB and was negative. I don't have like any other data because it's lacking, but the next aliquot will reveal the final diagnosis. Maybe, sorry guys for that.
That's okay. Gabrielle, remember what I said? I love your cases. They make me happy and nervous. And you're doing exactly the same thing right now. And the truth is, I'm not really nervous because I have the one and only Azim, who has the ability to pat himself on the back as he demonstrated. So, my dear friend, take it away.
So I think the thing that first stood out to me was the white blood cells being 1.9.
Yeah.
I wonder what the neutrophil count is, but I don't know. I'm thinking I guess the thing that in the context of the fever, I'm thinking of like febrile neutropenia, possibly, unless we don't have that data, which would just speak to the severity and acuteness of this patient, raising again the idea that it's an infectious. And in the X-ray, when I hear reticular nodular, I think TB. I don't know if that's more of like a buzzwordy thing for board exams, but that's also raising in my mind. Patient's anemic. I can't really. I mean, I'm sure infection can there could be like a hemolytic anemia play. I don't really know how to connect that with thinking of like a TB or HIV kind of context. And then for the chemistry labs, the thing that stands out is the albumin. I didn't expect it to be that low. I mean, when I think of decreased albumin, I think, well, what's the status of the liver, or if there's some kind of nephrotic process going on. But then you would have seen, I guess, some sense of that in the physical exams. Maybe seeing just crackles is enough to say like there's some edema or something going on. But I don't know. It doesn't feel like we're that kind of picture. But yeah, I think TB and HIV and infection continue to be more evidence for that. Platelet is, I think, borderline. I think anything less than 150. So I don't know. The discussion about whether there's like an underlying chronic disease or process for this patient, and then on top of that you have an acute insult. I like that picture. more. But I guess I'll leave it at that. But yeah, definitely I'd like to see like an HIV test and maybe well, it does say TB's negative. I'm seeing that now. So yeah, I don't know. That's kind of my thoughts, but it just points to the acuity, I think, of what's going on too.
Absolutely. Here's nothing but the truth. I love it when you discuss, because I think that you don't try to put glitter on what can be accomplished with the data that you have. You're very authentic. You're like, this is what I have, this is what I know, this is as far as I can take it. And now you are here religiously in your ability to in your desire to learn and grow and grow and grow. And I'll tell you that when I was in your shoes, there's no way that I would have been able to say more. And I probably, to be honest, actually would have been vulnerable to saying more simply because of the performative aspect of a lot of what we do. I might have fallen trapped into that. So I really, really, really can't thank you enough for sticking true to what you know and being comfortable saying that. And I think that's the real message here. The real message here is not like, oh, histo, 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 which I will tell you honestly is the itch that I'm feeling for this case. It's not what the purpose is, even though that's where I think we're going to end in a world like that. The real purpose of this is to be like, okay, 20 years from now, 30 years from now, everyone who's here now, how can we all be better? Because all of us want to be better, right? And I think the mistake to make is to pretend like to pretend that we all know more than we do. And that sense comes from seeing all these people around us who primarily driven by more time and more training do know more. And the ability to be like, actually, no, I'm invested in me. And I'm going to tell you what I know, and then I'm going to pay attention to what you can teach me so I can know more tomorrow. That's where it's at. And the learning is easy, I think. Well, the harder part is being authentic with yourself and not lying to yourself and pretending like you know more. And every time you talk, I'm just like, I never hear a sense of a kind of you taking a guess or like exactly what you're encouraged to do when you're taking step 1 or step 2 when you're getting like you're just always so authentic. And we're paired up today, but I'd say, Shannon, like, if you reflect on what you contributed today, you contributed a lot of knowledge and you contributed a lot of authenticity. You're like, here's what I know and here's what I don't know. It's clear. It's crystal clear. And I'll tell you, I fall prey to that all the time. I always kind of just maybe push more than I know. So I encourage all of you. Like, that's really what we're here to do. And I hopefully 20 years from now, we'll be grateful for being crystal clear on our understanding of where we are and all our pursuit to get better and better and better. And I'm going to do the same.
Robbie,
yeah.
So sorry to interrupt you, but I totally forgot. We also did a HIV test, and it was positive, and the CD4 count was approximately like 40.
Okay. Oh, Azim.
Yeah, it was very important there. So
that's totally okay, my dear friend. Here you are. Look at that. Gabriel, by the way, thank you for doing it this way, because it really validates everything that we just said about Azim and his authenticity and his asking for HIV. You asked and you shall receive. What do you want to, now that you know this, anything that you want to add?
Yeah, so the patient's certainly immunocompromised.
Yeah.
I'm thinking of those like opportunistic affections that could be at play.
Yeah.
I mean, I think I don't know if like PJP is something to consider, but it would fall under in that line of like something we thought was initially in the HPIs like bacterial, and then we talked about that initially as a fungal etiology could be something that's ongoing. And I think I saw something in the chat about the sensitivity about the TB being negative, but I don't know. I feel like maybe I don't know if a CT is going to be in order or not, but just thinking again, like big picture, that just proves I think we can get rid of like, we can lower the idea of like some kind of endocrine pathology at play or metabolic as much. And I think we can hone in on an infectious etiology.
Yeah, brilliant. Perfect. I'm right there with you. I'm taking my nickel and I'm throwing it towards histo, and I'm going to tell you why, but then I'm going to take it back and tell you that you shouldn't do what I just did. Okay, that's the goal. The argument all along from Charmaine and Shannon was this is a granulomatous disease, right? You heard them say granulomatous multiple times in their conversation. And Azim, you picked up on the notion that actually there's two diseases here. There seems to be this background disease that we now know is HIV, and HIV with advanced immunodeficiency. So what connects the two? I think when you're thinking about granulomatous disease, you recognize humbly that there are autoimmune conditions like Shannon mentioned, sarcoidosis and malignancies and drugs and all sorts of other things. But the truth is, as you outlined already, an acute inflammatory granulomatous disease is infection until proven otherwise. And the infections are many. Gabrielle, my friend and arch emesis, because he stumped me multiple times, presented a case of Bartonella causing a disseminated granulomatous disease, which is not present today because Bartonella does not cause pulmonary disease. So, you're not going to stump me with Bartonella today, my dear friend. But their whole list of mycobacterial disease, brucellosis, salmonellosis, nocardia, so many. Of the bacterial ones, which ones have a propensity for lung and skin? TB, and nocardia. Propensity, all of them can do it, but propensity. And you're spot on. You should listen to the most recent human diagnosis case with Lindsay, and I will say nothing more than that will teach you the utility and the performance characteristics of diagnostic tests for tuberculosis. If you think something's not tuberculosis, think again. And again, and again, and again, and again, and again, and again. I bet TB doesn't even recognize itself. That's how hard TB is to diagnose. So those are the bacterial ones. What about the fungal ones? There are many, Travis, just so you know, your Twitter is being shared. All good. Behind the scenes.
I was clicking Kashal's link that he shared. And I was trying to copy it, but thank you, Kashal.
All good. I just wanted you to know in case you're opening up your messages or whatever. Yeah, so Mycobacteria Endocardia are the bacterial ones. The fungal ones, there's a whole plethora of fungal causes. Now, this is where you have to study the syndrome itself. If you marry HIV and fungus, what spews out is Cryptococcus. Now, is that true? No. There could be, if you marry HIV and fungus really in general, you get PJP and Cryptococcus as base rate. But when you're in the world of granulomatous infection, because of the erythema nodosum, the reticulonodular inflammation, PJP is not a granulomatous infection. So if you marry HIV with granulomatous fungus, you get Cryptococcus. But this is not crypto classically. If you study this disease, this is a granulomatous disease with a propensity for the upper airway and bone marrow. Let me tell you about all the other granulomatous diseases that are fungus and their propensity. Sporothrix, skin and joint. Blasto, skin, joint, brain. Tularomyces, which is endemic in East Asia, skin, bone marrow, adrenals. Paracoxy, upper airway, but almost exclusively in men. 9-to-1 ratio men to women for paracoxy. Okay? Coxy, bone, meninges, skin. Histo, it lives in macrophages and disseminates to the adrenals, to the bone marrow, to the GI tract, and is much more common to present as a disseminated disease in patients with HIV. So what could this be? This could be any granulomatous infection under the sun. The signature of this granulomatous infection, it has a propensity for the skin and the bone marrow, which would prioritize tuberculosis, nocardia, and histoplasmosis. The depth of the pancytopenia here is much more characteristic of histoplasmosis, which again is a feature of patients with advanced HIV. So what you'd probably be trying to do is you're trying to chase TB and histo at the same time, which is unfortunately like Tom and Jerry. You're commonly trying to chase them, and often you don't catch any of them, and you just watch yourself catching your own tail. So hopefully you get lucky. You get TB somewhere, or you get histoantigen or antibody, serum, urine. But this patient either needs RIPE or needs amphotericin, overwhelmingly so. And the question often is in real life. This is fake life. In real life, the question is, do you empirically give RIPE or do you empirically give amphotericin for the possibility of these two things while you wait for diagnostic clarity? So I think that's where we stand. Yeah, I'll leave it at that. Back to you, Gabrielle.
Yeah, so they did a bone marrow biopsy showing macrophages with yeast suggestive of histoplasmosis. And I wanted to make a reflection on this case because I know this diagnosis was presented in cases before, and literally I remember I heard one postcard episode of histoplasmosis, disseminated histoplasmosis, and literally the day after that, I discussed this case with my respiratory professor, and the case was I suggested disseminated histo, and it was turned out to be that. And also what I learned from the case was about the erythema nodosum, because as you guys said, we also thought of sarcoidosis because of the pulmonary findings, erythema nodosum, and because she's basically the epidemiology also links to that. But I learned that histo, when it's presented in very immunodeficient patients, the pathology could also show non-cascading granulomas and showing erythema nodosum that is not commonly presented in histoplasma, but in severe immunodeficient patients, sure, histoplasma can be a differential diagnosis. Talking about the dermatology and about the ulcer in the mouth was also suggestive of histo. Here in Peru, when we see ulcer mouths, maybe respiratory findings, we think basically in two etiologies. First, paracocci because of the epidemiology, and then histo. And yeah, so linking that with bone marrow suppression, the pancytopenia, histo was the most likely diagnosis. And I enjoyed very much with your discussion. And let me finish with that. So this case is actually very interesting because treating HIV is clinically effective. There are the antiretroviral therapies effective, but what predisposes the patient to be severe and not taking their medications are social and economic factors. So the Venezuelan crisis, the social crisis, the migration process that all the people from Venezuela do percutates in their health, and it's a way. I think this case also. I wanted to remember that taking in consideration the social factors too.
Gabrielle, I'm just always blown away by your thoughtfulness when it comes to medicine and all aspects of life. So thank you for remembering this patient, remembering her story, where she's coming from, and also what and also teaching us so much. I learned a lot from you, and always, and especially in this, having the opportunity to discuss this case. Thank you. Shannon, Azim, I'm such a big fan of the two of you. Thank you. Robbie, always learn from you, my friend. Priyanka, do you want to take us away, friend?
Definitely. Thank you, Gabrielle, for such an awesome case. And I want to echo what Charmaine said about your thoughtfulness. I love the reflection on like the structural factors that affect patient outcomes. So thank you so much for sharing that. So this case started off with the chief concern of shortness of breath and confusion in a relatively young person. And I love that in the beginning, we pretty much left it at that, and we're thinking about some of the broader buckets that are associated with shortness of breath and confusion, but also invoked this idea that we really need to layer on more information from the patient's past medical history and the patient's age to develop a more accurate schema. Things that we asked about initially were, are the shortness of breath and confusion part of the same disease process? Did one cause the other? Or are two different organs affected? And I think leaving it broad allowed us to really take in the next aliquot and layer it onto this chief concern in a relatively young patient. Another thing that we learned in the HPI was this idea of increased thirst, which I just love the discussion on increased thirst because personally, I don't really think about it that often. So I'll comment really briefly that increased thirst can be due to a physiologic response to illness, like primary polydipsia, or a pathologic response, primarily due to solute or water loss due to the lack of ADH, which is commonly seen in diabetes insipidus, either nephrogenic or central diabetes insipidus. So I loved thinking about that. And if we were to further go down that path, we would have probably ordered some more urine studies in the labs in the objective data. We also started to think more deeply about localizing the symptoms. One of the big things that came up in the HPI was this productive cough that the patient had for 3 months. And typically, cough localizes to the lungs over the heart. However, it's important to consider the heart as another organ that could be a signature for cough because it could be the localized or the center point of edema, or cardiomegaly could be pressing on other structures, causing a cough. And so while cough commonly localizes to the heart, while cough commonly localizes to the lungs, it's important also to consider the heart. However, further substantiating our hypothesis that the cough localizes to the lungs, we have other things that lead to inflammation in this HPI. So those include the weight loss, the fever. And so inflammation, along with cough, further localized us and centered us in the lungs, which is where we started to think about more what diseases could be happening, what disease processes could be happening in the lungs. The physical exam was an awesome, I think, pivot point in this case for us because it elucidated a lot of physical exam findings that helped us propose some hypotheses. So we collected more clues here, and those clues included oral ulcers. We saw some erythema nodosum and a rash to the chest. And this begged the question of, is there a background autoimmune disease process going on with an acute insult versus an infectious etiology here? The erythema nodosum was, I think, one of the most important findings in the physical exam that allowed us to narrow down our hypothesis. Erythema nodosum can be due to a variety of things, including medications like antibiotics or birth control, particularly in a young woman like this one. Or it could be autoimmune in etiology due to sarcoid, granulomatous disease, IBD or Behçet's, or it could be due to malignancy. Layering on the erythema nodosum with the reticular nodular opacities that were seen on the chest X-ray also, fit into this hypothesis ultimately that what is going on could be an acute infectious granulomatous disease. I loved Robbie's teaching at the end about the different granulomatous diseases and their signatures. And so I won't go through all of them, but I have it here in the teaching points. But I think what the big takeaway for me was trying to think about the acute granulomatous diseases, the infectious ones that have a propensity for the upper airway, the skin, and the bone marrow. And the bone marrow, because we saw that all 3 cell lines were down. And so we thought about bone marrow processes being affected as well. And so for that, we think about TB endocardia in the bacterial bucket. And then in the fungal bucket, we think about histo. And I think the histo came really to the top of the hypothesis because this patient later we've learned was HIV positive, and histo is very commonly seen in HIV patients. Although I do think that the bone marrow biopsy was necessary, as we saw here, to determine the final diagnosis. So that's all I have for you all. This was an awesome case. Thank you so much, Gabrielle. Have an amazing Thursday, everyone.
That was awesome, Priyanka. Thank you. Thank you all. Have a wonderful rest of your day, and we'll see you soon. Bye.
Thank you. Bye.